Hey, good morning, and welcome to the UroPatient podcast. I'm your host, Vic Senese. Welcome to the show. We come to you every Saturday at 10:30 a.m. Central Time, and we're on YouTube and Facebook and LinkedIn. You can catch us anytime you want live at 10:30 a.m. Central Time or on demand later. Hey, if you're new to the show, be sure to check out our website at UroPatient.com, the best place to go to catch all of our past episodes. We got a bunch of them there, so be sure to check them all out. We got 69. This is episode 69, so there'll be 69 of them in there. Also, we have this helpful handout area. Just go to the handouts and download a handout. Almost everything we've ever put out on video, we have a handout that accompanies it. So check those out. It's a good place to check things out. So this week, I got a great show for you. I have Dean Elterman. Dr. Dean Elterman is a urologist out of Canada, and he recently presented on something called FITS and MIST. Now, if you're not familiar with those terms, don't feel bad. They're pretty new terms. MIST has been around for a while, which is minimally invasive surgical techniques, and these are referring to prostate treatments. Now, we've talked about some of those. We'll review some of them again, but those are the ones we do in the office, like Rezūms and UroLifts, etc. Now, there's a new line of therapies that are just about FDA approved. They haven't quite gotten out, which are called FITS, which is first line therapies. So anyway, first line interventional therapies, that's why it fits. But it's the things that are going to come even before the MIST. So these are really neat. These are some new takes on stents that can be placed in the prostate. They've figured some stuff out, and they're getting really good results in the testing. And these are going to be super easy to be put into the office. So let's let Dr. Dean Elterman go ahead and explain it to you.
So the market, though, is really underserved. And what I mean by that is if you look at this whole cohort of men in the US suffering from BPH, the vast majority of men, 2/3, are just living with their symptoms. They'll never even see a doctor, or they're buying things late at night on television or on the internet or herbal products. And for those fewer men who actually get on to see a doctor, to see a urologist, to see one of the urology nurses, a portion of them are going to be waiting and watching their symptoms. About half are going to go onto drugs, and then a quarter of them are going to fail medical therapy. But in fact, in the US, a very small proportion of men actually make it to the doctor, make it onto drugs, fail those drugs, and then get on to an actual type of intervention. So there's a huge number of men that just fall off the back of the wagon, and who knows where they go. They're back to the beginning of the cycle where they have their symptoms unmanaged. So that has really, I think, been the reason why these minimally invasive treatments and FITS and other things I'm going to discuss have been born. They've been born to fit an unmet need. And that unmet need is men not wanting to be on medications or not wanting to have a more invasive surgery. So when we compare and contrast all of the different available options, drugs, yes, they're non-invasive, they have a modest effect, but they have all that list of side effects in green. Of course, surgery has a really good durable outcome with significant benefit, but of course, full anesthetic, catheterized, recovery time is long, risk of incontinence and sexual dysfunction. So the minimally invasive therapies, or the MISTs, they really are more geared towards patient preferences, right? They're well tolerated, they can be done under local anesthetic, they improve quality of life and flow, but they preserve sexual function. They do give durable results, not as good as surgery, but the levels of satisfaction are really, really high. And so I think that's where men and their doctors need to be able to talk about what suits them best. This was a really interesting study out of Europe where they asked men what is important to them. And consistently, men said that they preferred less invasive treatments with lower risk of side effects compared to more invasive treatments that maybe have better durability, like a TURP, but have more risks. And for them, sexual dysfunction was the most important aspect when decision-making, followed by wanting to avoid side effects. And men are also really bothered by those OAB bladder symptoms like urinary urgency incontinence, waking up at night with nocturia, frequency. Those are the things they want to have addressed, much more so than even a slow stream. We even had a study looking at groups of men who had recently had surgery or were considering surgery, and we looked at them. The vast majority, 90+%, were really concerned about sexual function, regardless of age. Younger men were most concerned about sexual function. Men in their 60s were most concerned about becoming incontinent. And even men over the age of 60, more than 60%, were still concerned with sexual function. And so all of these are really important, and patients value keeping sexual function and safety even over effectiveness or durability. So that's, as I said, why we have all of these minimal invasive treatments that have been invented, essentially MISTs, to bridge that gap. They're more beneficial than medications. They have a lower risk than our traditional TURP, whole-leb, green light, prostatectomy, etc. And so when we're looking about patient expectations, we're talking about what do they want? They want something non-surgical, less anesthetic. They want efficacy for sure. They want effective treatment of their symptoms. They want improvement in their quality of life, improvement in their flow. They want it to be a well-tolerated, a good experience. They want to say, I had a great experience getting XYZ with my doctor, with my urology team. And if ideally, if they can, they do want to preserve sexual function. So currently in the United States and Canada, where I am, there are 4 FDA-approved minimally invasive surgical therapies or MISTs. In no particular order, starting in the top left, we have the iTind, the temporary implantable nitinol device. We have the UroLift, prostatic urethral lift. We have Rezūm, convective water vapor thermal therapy. And we have the Optilume, drug-coated balloon BPH system. We gave a previous lecture about this on a previous episode here on UroNurse. You can look back in the archives. So everything starts with patient selection. It's those men who want to stop medications or don't even want to go on meds. They may want to have a minimally invasive treatment. They're not receptive or open to a more invasive surgery like TURP. Maybe their symptoms aren't bad enough that they want to have drugs every day or a big operation. So asking patients' preference is really, really important, and you want to set their expectations. You don't want to overpromise. These treatments, MISTs, are not the same as getting a TURP at all. And you want to understand why they want to have a MIST. Is it to preserve sexual function? Is it to avoid surgery? There really isn't a specific type of patient. I see people from all walks of life, from all socioeconomic backgrounds, and regardless, many, many, many of them are going to be interested in a MIST. So again, just going through some of these, I know for the experienced urology nurses and people listening to this podcast, you're really familiar with these. But again, the UroLift, prostatic urethral lift system, was the original MIST in sort of the modern era. We're talking past TUMT and TUNA and some of those older technologies that you might be familiar with. So there's a stainless steel side, there's a nitinol side. It's connected by a Prolene suture. It's using a specialized scope. You compress the lobes. This is really important. And then you shoot this anchor through the prostate, and it essentially squeezes the lobes together, allowing an opening of the tissue, particularly anteriorly in the prostate. So you place these about 1/3 from the roof of the prostate. There have been studies showing very good durability out to 5 years. The retreatment rates are in the range of 15%. And if you add some other interventions, it's about perhaps 1/3 of patients. But the advantage, of course, is that most patients are able to go home without a catheter. The recovery is the fastest amongst the minimally invasive treatments, and it preserves sexual function, including ejaculation. There have been some studies comparing UroLift to TURP, and the takeaway is that TURP, of course, improves symptoms, IPSS the greatest. However, on all other aspects, so recovery, erectile function, ejaculatory function, continence, safety, UroLift beat out TURP. So you have to look at other factors beyond just flow. Rezūm is convective water vapor thermal therapy. I think everyone's also familiar with Rezūm water vapor ablation. We see on average these lesions that we create in the prostate completely go away by about 6 months. We see on average prostate volume shrinking by about 30%. The transition zone, that middle obstructing part, shrinks by about 40%. The retreatment rates are actually lower than that of UroLift. Around 4% of men will need another intervention, 10% going back onto drugs. Rezūm can be done for bigger sized prostates with very good effectiveness. And the retreatment rates look quite good, certainly better than medical therapy and some of the other minimally invasive therapies. This is the Optilume BPH catheter, as I said in a previous episode, we've gone through this, but this is a drug-coated balloon. There's a pre-dilation balloon that stretches the prostate. It causes the prostate to open at the 12 o'clock position. This is called an anterior commissurotomy. The second balloon that has the paclitaxel drug coating goes in, and what it does, there are these 4 different lengths, different sizes. So the sizing is based on the length of the prostatic urethra. So you have to take a measurement from the bladder neck to the external sphincter, and then you match that to the different balloon lengths. So it's not so much based on volume, more on length. Here's a before and after picture. You can see before the prostate is kind of shut down like a letter A. Afterwards, it opens up in the roof like an inverted U. And a year later, it remains open because the drug, the paclitaxel, prevented the tissue from closing down. Now, you may not think that looks very impressive, but the data does show significant improvements. This is what it looks like intraoperatively. Studies have shown significant improvement in flow, very significant, as well as reduction in PVR, no sexual dysfunction, low retreatment rates. So compared to some of the other myths, the flow rates are actually very much like a TURP. We're seeing 113% improvement in flow, going from about 9 mils per second to 20 mils per second. So it's really significant. So iTind is available in the United States. It's FDA approved. You could argue that this is the first TMIST. This is a temporary stent placed into the prostatic urethra. It goes across the bladder neck. It has these 3 struts or arms at 12, 5, and 7 o'clock. It's left in place for 5 to 7 days. It slowly expands during those 5 to 7 days, causing ischemia and an opening of the prostate in those points. And so here on this screen, I put together essentially all of the new stents. I call this my stent 2.0 slide. And you can see some you're familiar with, UroLift, iTind. You could argue those are types of stents. But we've got a whole bunch of new ones coming down, finishing clinical trials now, that will be on the market really, really soon. I'm going to go through some of these, but this is sort of the future of where the minimally invasive space is heading, at least in the next couple of years. So this brings into this idea of FITs, or FIT, first line interventional therapy. So about in January, after about a year of talking about this, Steve Kaplan, who's in New York City at Mount Sinai, and I came up with this new way of thinking about these prostate stents, or at least this new category of treatments that we have called FIT. So what is a FIT? So FIT, first-line interventional therapy, is again this new paradigm that bridges the gap between medications and surgery. A FIT aims to provide effective, minimally invasive symptom relief that has a rapid recovery, minimal side effects, and preserved treatment adaptability, meaning you can do something in the future if you need to. So the ideal FIT should be outpatient, it should have durability, and it should be focused on patient-centered outcomes. Remember, we talked about what do patients want, and it should address those expectations both for the patient and the urologist. So we think by reimagining this, FIT could potentially revolutionize, really change the way we manage LUTs. It's going to shift the standard of care earlier, effectively, in more patient-friendly interventions. So instead of going on drugs, waiting many, many years for symptoms to progress, waiting for bladder dysfunction, trabeculation, PVRs going up, going into retention, we want to bring men in to have one of these FITs. They're going to be performed in an outpatient, flexible cystoscopy, minimally invasive, no anesthesia required. That is what a FIT is going to be. And FITs really cover all of these new prostate stents. So I'm going to go through several of these. None of them, I will emphasize, are yet FDA approved. They are under investigation. Many of them have been presented at international meetings, so I can show you some of the data that I presented at like the AUA last year, for example. Their studies are wrapping up, and we'll see when they are going to hit our market. So this is the ZenFlow spring system. You can see there, it's this coiled or helical, almost like a corkscrew. It goes through a proprietary special cystoscope you can see on the top right. Studies have shown very similar to the MISTs available by the FDA approved, about 50% improvement in symptoms, flow rates improving, and this one has been sustained out through 2 years. So this is going to be one of the minimally invasive fits coming out. There are different lengths based upon the prostatic length. You'll choose whether you want to do extra small, medium, etc. This is another American company. It was designed by a urologist. This is the Rivermark flow stent. What's unique about this is that it's delivered through any flexible cystoscope. So you essentially just backload it into the tip of the cystoscope. You go in with your flexible scope. You use a little grasper to deploy it and push it out. It's just inside the bladder neck. And studies in Australia and New Zealand have already been able to show significant improvements. We did the first-in-man study down in Panama a couple years ago, and we showed, again, you can see those IPSS improvements going from about 25 down to 6, 5, 2, 2, really good improvement in flow and symptom improvement. This is the Proteon UroCross Expander. This is another device. It has a delivery system that fits through the working channel of a flexible scope. So you can see on the right, on the bottom, that white part that goes into your port. You screw it, you lure lock it in place. You advance it down through the tip of the scope and you deploy it into the prostatic urethra. What's unique about this is that it's designed to stay in for 6 months and then it's removed. The idea being like the iTind is going to expand but reshape the prostate through ischemia, and once it's removed, it will stay open. This is an Irish stent called Provirum, and the device is called the Pro-V. It is delivered originally through a rigid scope. They now have a flexible scope. It's a 3-sided sinusoidal design. It's also made out of nitinol. They're all made out of nitinol. And they've just finished the North American study that we completed, and the data is being analyzed, and it will go to the FDA very soon. This is another one that also just finished their study that we were involved in. This is called the Butterfly device. It's also delivered through a scope. And I guess what's different is that it's from the top down. So you can see the arms and the wings and the spine there. So almost like a UroLift, you place it into the prostate, but it's kind of up towards the roof of the prostate, and then it expands outwardly. And so that is another design. We'll see where it goes, but they have some early data, and they've finished their study, and it will be coming to market. So those are all examples of first-line interventional therapies, prostate stents designed to be performed in the office with a flexible cystoscope, maybe done earlier, maybe as an alternative to medical therapy. So I definitely think we've learned from our past failures 20, 30 years ago. The material with nitinol is much better, much less prone to encrustation or migration. They're really easy to put in and to remove with a flexible scope. And so my final slide here, talking about MISTs and fits, they're here. I think they're here to stay. They're being designed to meet the demands of our patients. Patients want lower risk treatments. They want to have less irreversible complications like incontinence or ejaculatory dysfunction. We all would like to be able to do these as outpatients so we can also treat more people. That demographic curve is just growing and growing. Our older population of men is growing. The BPH burden is increasing year on year.
All right. Well, I hope that was interesting, and I hope you know a little bit more about what options there are for your prostate. And if you're having problems, definitely go see a urologist, because there's no reason that you should be getting up in the middle of the night several times and having a weak stream and all those other things, when you can get something done about your bladder a lot quicker by getting one of these procedures done. Check it out soon. And we'll see you again next week at UroPatient.com.